Today we're going to talk about the prevalence of dissociative identity, not just dissociative identity disorder, but all the dissociative disorders.
Right.
And the reason that I made that confusion is because it's really difficult to get information.
That's right. It's not unusual to make those kind of mistakes when you talk about this disorder.
Right. So dissociative disorders is the broad class, and dissociative identity disorders, one of the more common, is I guess the most common within the family.
Right. The most talked about, the most discussed, right?
Yeah.
And certainly the most popular in the media,
and maybe even the most controversial at the same time.
True. Yeah, it really is.
And it is difficult to talk about the prevalence. And we're gonna kind of review an article from the Harvard Review of Psychiatry. The link is in the show notes, that talks about some of the myths associated with dissociative identity disorder. Again, because that's really the main one that gets a lot of attention and focus in research and in media in general. But some of the common myths associated with why it's so difficult to talk about the prevalence.
Right. We talk about the myths, but contained in those discussions of the myths are the diagnostic controversies, the potential errors that you make.
Right.
But it's what concerns us the most when we have a possibility of making this diagnosis, and the things that we need to be really, really cautious about as we work our way through this differential diagnosis. This is not an easy diagnosis to make by any means, nor is it an easy diagnosis to treat, which we'll talk about later in the week.
Right, absolutely. So the link again is in the show notes, and so you can read the article in more detail.
Right.
But the first myth that is described is that dissociative identity disorder, the diagnosis and therefore the prevalence of dissociative identity disorder is influenced by the myth that it is a fad.
That's a fad diagnosis.
Right. So it's sort of meaning that it's that it goes through a period where a lot of people are making this diagnosis because it was something in the media, or there was some popular attention made to it, and so it increased the diagnosis of the disorder.
Right. You can see that. I mean, we use the term diagnosis of the day, diagnosis du jour, diagnosis of the day. Sometimes these things creep into the culture, and they become popular. And you can imagine a high school class or a college dormitory where one of the students might get the idea that he or she has, frequently it's she, has this multiple personality, this identity disorder, and it spreads through the group, it spreads through the culture, the subgroup, and people start looking it up and they, I think I have that too, and maybe you have it, and you can see how it will spread.
Right.
And that may have happened recently because we are getting more inquiries about this diagnosis. However, we have to remember that this diagnosis was first written about in 1586.
Right.
And again in the 1790s. So it's certainly not a new diagnosis. It has been described in the literature for hundreds of years. And so it's not a fad diagnosis.
Right.
It was redefined in 1994. So in that sense, there's been a recent revision in I think it was 94, 97, and 2011, 2005 and 2011. So there have been some revisions along the way. But it's not a new diagnosis by any means.
Right. And certainly one of the things that would kind of suggest that it's a fad, even though it's not, is, of course, the internet. Anytime someone experiences symptoms that are unusual to them, or they feel like they don't, some of the common things is, I don't feel like myself.
Right.
And as soon as a search is done on Google or whatever to look at those symptoms, what would cause that, one of the things that could come up is dissociative identity disorder.
Right.
And so people will start looking at that, and they will start reading about that, and when they go talk to their physician, they will certainly present information consistent with the diagnosis. And we've talked many times before about how I don't necessarily think that anyone has malicious intent when they do something like that.
Right.
But you can certainly present common symptoms in such a way that they could you know, appear to meet criteria for any number of disorders.
Right. And people do that all the time.
Sure.
I mean, now that all this stuff is easily accessible on the internet, they will come in and describe the symptoms that are attached, that are associated with a certain disorder, because it's that diagnosis that they're seeking. Usually it's they want a diagnosis, but sometimes they want the treatment, drug or non-drug treatment that goes with it.
Right. And so that sort of leads us to the second myth, and that is that dissociative identity disorder is primarily diagnosed in North America by dissociative identity disorder experts who overdiagnose the disorder.
Yeah, and there were two issues there. One, that it's a diagnosis that's most frequently made in North America, and the second is that it's being overdiagnosed.
Right.
Let's take the North America issue first. No, this is a diagnosis that's made across around the world.
Right.
In fact, in some cultures, dissociative disorders would be considered demonic possession.
Right.
Okay. They see the same characteristics. They name it something very different. Okay.
Right.
So this is not a disorder that's unique to the United States or to North America. And in fact, one of the primary professional organizations, pods, is in the UK. Okay, so this is not something that's unique to North America, and we certainly don't have a monopoly on it. It may be called something different, but it occurs around the world in one name or another.
Right.
Same with overdiagnosis.
Same with being diagnosed only by certain a handful
that only
of
certain people can make the diagnosis or do make the diagnosis.
Right. And the research suggests that, no, it is diagnosed by many different people, a variety of professionals, not just people who are DID experts, but also that it's not as overdiagnosed as one might think.
Right, right. The data suggests that it's not being overdiagnosed. Right. Is it becoming, and by overdiagnosed we mean applied to the wrong people. I mean, certainly the issue may come up more frequently, but the problem isn't misdiagnosis or overdiagnosis. The problem is people are asking the question more often.
Right.
I don't think professionals are necessarily getting it wrong, or that we're misdiagnosing, or not misdiagnosing, overdiagnosing. Right.
And I think that part of that is because it's still relatively unknown. You know,
it's relatively rare.
Right. A lot of people don't. It's not like autism. Autism is getting a lot of attention from a lot of different places, and so just about every medical professional knows something about autism.
And once these disorders make their way into the popular culture,
mainstream.
For example, when Michael J. Fox announced that he had Parkinson's, people learned about Parkinson's. People learn about ADHD. People learn about autism. People learn about this, and this may be a case of this simply entering the popular culture and therefore becomes more commonly discussed. Doesn't mean it's being overdiagnosed, because in fact the data, the epidemiological data, suggests that the 1% has been fairly stable. The 1% prevalence rate has been fairly stable over time.
Right. Now, that gets us to the third myth, that DID is rare.
That's a myth.
That's
it's
myth.
Rare.
Right. And in fact, based upon the epidemiological studies, it's just about as common as bipolar disorder and schizophrenia and some of the other disorders that we don't necessarily consider to be rare. It's about sometimes up to even 3% of the population, depending on the study.
Right. And that's true for bipolar disorder. And we tend to think of bipolar disorder as far more common, and when in fact epidemiologically it isn't. And it's not more common.
And so that does, again, get us to the point that even bipolar disorder isn't as common, I think, as most people think it is.
Exactly. Yeah. So not everybody has bipolar disorder.
So we wouldn't call it rare because it's about as common as many of the other conditions that we think about. But it's, the likelihood of, presenting with it is still small.
Still small.
Now, the fourth myth is that a DID is...
one of my favorite words.
Go ahead.
Iatrogenic.
Iatrogenic. that it's an iatrogenic disorder rather than a trauma-based disorder.
Right. And the word iatrogenic means that it is a disorder that is brought about by the exam itself.
Right.
Okay, that the medical exam or the treatment, or that you go into the office and you're asked certain questions and you say, oh yes, that's what I have. Okay, so the cause of the disorder is the medical examination itself.
Right. And now, that is not to say that doesn't happen.
Good.
It's just that that's not what typically happens.
I'm
That
glad you
doesn't explain
Right.
the vast majority of the diagnoses.
But that concept, the whole idea of iatrogenic disorders is common in every field of medicine,
Absolutely.
but especially in psychiatry and psychology, because it's easy to ask leading questions. It's easy for me as a clinician to assume that a person has this disorder, and I ask those questions to confirm my diagnosis or my hypotheses. And that's just a professional issue that we have to be careful of, that we don't lead patients to a diagnosis.
Absolutely.
That's not the patient's responsibility, that's our responsibility.
Right. Yeah, this is, and instead, this is a condition that's trauma-based.
Right.
You know,
That's right.
It is a disorder, a set of conditions that comes about following or in response to a significant traumatic experience or multiple traumatic experiences.
And he means significant.
Right.
I mean, it takes a considerable amount of trauma to move a person into this direction.
Right.
Okay?
And we're going to talk about that tomorrow.
Yeah, we're not talking about incidental trauma. I mean, think of all the soldiers who return from wars, or firefighters, or first responders, people who are exposed to trauma every day. We're talking about a significant amount of trauma over time that would lead you to need this sort of protective capacity.
Right. Right. Now, the fifth myth is one that we kind of alluded to yesterday, and that is the fact that DID is the same thing as borderline personality disorder.
Right.
Good grief. But DID is not the same thing as borderline personality disorder.
This whole area of dissociation should not be confused with personality disorders.
Any of the personality disorders.
You'll hear those words. You hear multiple personality disorder or personality disorders. Don't be confused. Dissociative disorders are in a different category, and they are because they're trauma-based, and because they have some unique characteristics, not to be confused with the second part of DSM-5, which is the personality disorders.
Right. Yeah. Some of the personality disorders can have their roots in trauma, but again, it's very different because that personality is that personality anytime, always, and forever.
Right, and it's not unusual to have symptom overlap.
Right.
But that goes with most diagnoses. Is you have symptom overlap.
Right. And the last myth mentioned here in the Harvard Review of Psychiatry is that DID treatment is harmful to patients.
Right.
We're going to talk a lot more about treatment on Saturday's podcast, but treatment is challenging, but we wouldn't say that it's harmful.
In the right hands.
Right, in the right hands.
And
when done correctly.
Right. If you've never done this before, be careful. If you're a professional and you've never dealt with these disorders, because the trauma shouldn't occur in the office.
Right.
But it might.
Right.
And again, that's the clinician's responsibility to make sure that this is within your scope of practice. Don't go dabbling in this area if you don't know anything about it.
Right.
Send the person to somebody who's done this for a while or done this with a few cases, because you could create problems. You shouldn't, if you're competent in this area, you shouldn't add to the trauma or cause the trauma, but make sure you have experience.
Absolutely.
Before you dabble here.
Absolutely. It is a bit of a complicated and multi-tiered treatment approach that's necessary. Again, we're going to talk more about that on Saturday, but in the right hands, as you said, would not cause harm to patients, and is unnecessary. But there's some things that you have to really think about with the treatment, and again, we're going to get into that on later this week.
But don't you agree that anytime you get into a trauma-based,
all of them,
any trauma-based disorder, you need to be careful about how you manage manage that trauma.
Right.
Okay,
Yeah,
how you
absolutely.
talk about it, how much you bring out, how much you feel the person can tolerate,
Right.
and you can feel people reaching a point where they don't want to take that next step, and you just have to have the clinical skills to know not to go there.
Absolutely.
Then take it up another time when
Right.
the patient is ready.
Absolutely. So for all of those reasons, thinking about and talking about the prevalence of these disorders is really difficult because people may not seek treatment. They may not go to get help for it. They may it could be confused with other things.
Right.
Any of these issues could raise complications when it comes to understanding the true prevalence of the disorders.
Right.
But it is here. It is real.
It's real.
We've certainly seen handfuls of patients with some of these challenges, and again, over the course of the week, we're going to talk a lot more about some of these issues.
But diagnosis and treatment and other problematic aspects of this disorder.
Absolutely. So, all right.
If nothing, it's confusing.
If nothing else. Until next time, stay happy, stay healthy, and forget to be afraid.